Hello everyone and welcome to this new lecture or a new research paper. Today we will search about some research papers here on Google Scholar as usual. It's going to be about dentistry, introduction to salines, let me find one and I will back to you soon. So this one is about Amalgam Free Dental School. The Amalgam Free Dental School abstract to review the changes in teaching, of restorative dentistry in the Jamin Dental School over the period of 1986 to the present. Key points: in 1986, Class 1 and 2 resin composites restorations were included in the preclinical program. However, these courses still started with Class 1 and 2 amalgam restorations. From 1990 on, the number of amalgam restorations placed in the clinic gradually decreased, while the number of resin composites restorations increased. Meanwhile, resin composite had become the first choice for the treatment of primary caries Class 1 and 2 lesions. Finally, in 1994, the preclinical training started with resin composite restorations before dental amalgam was taught, and the advantage of minimal preparation was further emphasized. Since 2001, the teaching of dental amalgam ceased at the dental school. This was not an abrupt change, but the result of a long transitional stage, during which it was gradually substituted by resin composites. This step-by-step introduction allowed the acceptance of composite resin by the staff as an alternative for dental amalgam and posterior restorations. As in 2001, students placed only 2.5 amalgam restorations before graduation. It was decided to stop with the preclinical training program. Conclusion: the introduction of resin composites meant an important change in teaching restorative dentistry at Nijamin Dental School. It was not just a change in materials and techniques, but also a change in treatment philosophy. The reduced need for preparation and strengthening effect of the remaining tooth were the principal reasons for the shift from dental amalgam to adhesive dentistry with resin composites at Nijamin Dental School. Introduction: for more than a century, dental amalgam has played an important role in restorative dentistry at all dental schools over the world. Dental amalgam has proven to be a reliable restorative material, and the preparation technique was based on the principle of GV black for amalgam. The cavity needed to be adjusted to meet the requirements of the restorative material and to provide macromechanical retention. As the principle of extensions for prevention was gradually accepted, the preparation was further extended, resulting in a considerable reduced strength of the prepared tooth. The introduction of the acid etch technique and resin composites meant an important change in restorative dentistry. It was not just a change in materials and techniques, but also a change in treatment philosophy. As retention was provided by the adhesive technique, the preparation could be largely reduced in comparison with dental material amalgam. An occlusal caries lesion restored with dental amalgam occupied an on average 25% of the occlusal surface, while it is only 5% for resin composite when the preparation was kept as small as possible. This adhesive approach, instead of the traditional mechanical approach following the principles of GV plaque, was propagated already in 1984 by Hosonda and Fusima. According to these authors, minimal tooth reduction restricted to removal of infected dentine followed by total etching afford maximal strength of the residual dental tissue and will maximize the longevity of teeth. The reduced size of the preparation and the use of adhesive technique will both have a positive effect on the survival of the tooth. The adhesion between the tooth material and the resin composite helps to restore the integrity of the tooth that is weakened by the carious lesion or preparation. An in vitro study has shown that the cuspal stiffness of endodontically treated premolars with a large MOD preparation largely recovers after being restored with a total etch technique and hybrid resin composite. Clinically, less cusp fractures are seen in premolars restored with an adhesive bonded composite resin restoration compared to teeth restored with dental amalgam. Until recently, it was common practice to prepare the tooth to meet the requirements of the restorative material and to focus on the improvement of the survival of restoration. However, restorative dentistry with adhesive techniques and resin composite will result in a preparation that is merely determined by the size of the pathological process. The restorative material does not require a standard preparation and can be adjusted to every material, to every cavity form. Meanwhile, the consciousness has grown that preserving sound tooth material is more important than making a long-lasting restoration. Nowadays, terms as minimal invasive dentistry or minimal intervention dentistry embracing this philosophy as well have become more popular. The reduced need for preparation and the strengthening effects on the remaining tooth were the principal reasons for the shifts from dental amalgam to adhesive dentistry with resin composite at Nijami Dental School. This decision was not influenced by the better aesthetics of tooth-colored materials compared to amalgam and possible adverse side effects of the material. In a report of the Committee on Dental Restorative Materials of the Health Council of Netherlands from 1998, it was concluded that there are no indications that any type of restorative material, including dental amalgam, will provoke systematic toxic reactions. The environmental effect of amalgam are low as amalgam separates are installed in every Dutch dental practice. A survey of Wilson and Major in 2000 among European dental schools showed that posterior composite restorations were taught in most of the schools. However, there was a considerable variation in technologies and indications. According to Newman, Every few dental schools in North America are graduating students with the skills or knowledge to perform posterior restorations with tooth-colored materials with a degree of confidence. Since 2001, the teaching of dental amalgam completely stopped at Niamey Dental School. This was not an abrupt change, but a result of long transit stays. With submitted, it was preparatory reasons for this turnover explained. Furthermore, the sequence of changes in the dental curriculum and the related problems encountered are described. Section snippets. Sequence of change in dental curriculum. Though resin composites have been applied for a long time in class 3, 4, and 5 preparations, they were first used in class 1 and 2 restorations in the Department of Pediatric Dentistry in the early 8th. Both resin composites and glass elastomer cements were sometimes an alternative for amalgam in deciduous teeth. GIC was considered as an important, temporary restorative material and only indicated for treatment of highly uncooperative children. In such case, the preparation was, etc. Effects on the curriculum, as is shown above. The gradual transition of teaching dental amalgam to resin composites required many changes. It had an impact on both the staff and the students. The step-by-step introduction probably helped to get resin composites accepted by the staff as an alternative for dental amalgam and posterior restorations, as in the beginning resin composite was only applied to treat primary caries lesions. The restorations were relatively small and the procedures not too difficult, etc. Conclusion to the change in restorative dentistry from amalgam to the resin composite is a step-by-step process that takes a long time. In the approach as described above, major failures and disappointing experiences are prevented. The survival rate of the posterior resin composite restorations placed by students appears to be quite satisfying, as can be seen in the article of Amalgam in the special tissue. In the beginning, not every instructor was supporting this change, however, etc., etc. There are acknowledgement and references you can read, but this is not a purchased, full documented research paper, as you can see, because it is behind a paid wall of $31. Most importantly, thank you for listening, as you understood most of what this article / research paper is talking about. It was talking about amalgam free dental practice. Thank you for listening and goodbye.